Well, good evening. I'm Holly Gulden, and I serve as Associate Vice President for Advancement and Executive Director of Development for Tulane University School of Medicine. We are all thrilled to host tonight's virtual event and to share the stellar work of our faculty. COVID-19 certainly has changed our world in many ways, and research has come a long way since our July 2020 COVID webinar. This evening, you'll hear the latest from two of our faculty experts. Bit of housekeeping first. During the presentations, please share your questions via chat. If all questions are not answered during the webinar, they will be answered individually by email after the event. With us tonight and sharing their expertise are Dr. Susan Hassig and David Mushatt. Dr. Susan Hassig received both her Master's in Public Health and Doctor of Public Health from the Tulane University School of Public Health and Tropical Medicine. She's been a faculty member of Epidemiology Department since 1996, after more than a decade of work in HIV research, surveillance, and intervention programs in the United States and around the globe. She also has served in the Peace Corps, where she worked to improve disease diagnosis methods and blood transfusion safety in Thailand. Dr. Mushatt is Associate Professor of Medicine and Section Chief, Adult Infectious Diseases. He received his MD from Harvard Medical School and completed his internal medicine residency training at the Brigham and Women's Hospital in Boston. He then did an infectious disease fellowship at Tulane School of Medicine from 1989 to 1991. During the second year of his infectious disease fellowship, he also earned a Master in Public Health in Tropical Medicine at Tulane School of Public Health and Tropical Medicine. Dr. Mushatt is principal investigator of the Louisiana Community AIDS Research Program, the Tulane clinical trial site that was formerly part of the CPCRA and now part of Insight, an NIH-funded international HIV research group that focuses on strategies in HIV treatment at the community level. Once our speakers are done, the questions will begin. We've had numerous questions posed with individual registrations. Thank you for that. And in addition, we will have our speakers answer as many questions as possible from the chat. At this time, it is my pleasure to turn the program over to Drs. Hassig and Mushatt.
Good evening, everyone. We're going to start with a little bit of an overview to set the stage for questions that we may have come up from our audience. And we're going to start with the big global view. This is a global problem. It is a challenge not just for the United States, but for countries all around the world. To date, we have had 192 countries report cases of SARS-CoV-2 infection, and over 111 million infections reported. This is probably, however, a substantial underestimate of the actual numbers of infections that have occurred around the world, because testing is not uniformly or widely available in many parts of the globe, and even in parts of our own country. David, if we could have the next slide. Getting a little bit closer to home, on the United States level, this is data as of last night. You can see very clearly the three peaks of surging cases that we've seen in the United States. Louisiana was very heavily involved in that first peak that looks very tiny right now, compared to the one that we just worked our way out of over December and January. And you can see the tremendously precipitous decline in numbers of cases that we've seen in the United States, but an unfortunate pause in that decline, which is actually, although tremendously lower than January, about the level of the summer peak that we experienced here in the United States as a whole. So we have come down a long way, but we still have some considerable infection being spread and acquired here in the United States. And so we need to continue to be vigilant. Next slide, please. The really good news is that the vaccines are here, and that we here in the United States have delivered a quite astounding number of vaccine doses into people's arms after only just a couple of months of delivery. We have seen a large number of individuals, millions, 27 million, I believe it is, who have, as of yesterday, been completely vaccinated with either the Pfizer or Moderna vaccines. And this is a very large number, three times the population of Israel. But for our population of 340 million people, it is only a relatively small percentage. So while we have made tremendous progress in delivering the vaccine, we still have quite a ways to go before we begin to see the public health benefits of that in a major way. And the next slide, please. The objective and the hope for our vaccine delivery and distribution is, of course, to make our population collectively immune and protected from further infection and continued expansion of the pandemic within our country and ultimately the global population through attaining herd immunity, which is an idea that means that if we have enough people in a population that are no longer susceptible to an infectious agent, it's just going to die out because it doesn't have anywhere else to go. We are moving a lot of vaccine on a daily basis. We have hit over 2 million doses per day now, and that is likely to only continue to go up as additional vaccines become available and production ramps up for them. But as you can see from the right-hand side of the graph, it's going to be quite some time before we reach the level of protection above 70%, which is considered to be kind of the minimal level that we need to reach to attain herd immunity. And then we have to keep it there. So it is a challenge that we are facing, but we have a lot of tools currently available to us to help make this happen and hopefully have us see the end of the pandemic in the relatively near future. And with that, I'm going to pass it over to Dr. Mushatt for some additional information on vaccines.
Thank you so much, Dr. Hassig. Fellow Tulaneans, it's a pleasure to be here. Thank you for turning out on this Thursday evening. So I'm going to dive into the vaccines now, and my presentation will be relatively short, and then we'll have time, hopefully, for plenty of Q&A. So the really good news is that there are over 70 COVID-19 vaccines in clinical trials around the world. That's absolutely astonishing in just a year of development. And on the left, you can see that there are actually 20 vaccines in large-scale phase 3 studies. And those are the studies that have to be done before, for instance, the FDA in the United States can give emergency use authorization. So that bodes very well. And at present, we have the 2 mRNA vaccines, Pfizer and Moderna. We have the Johnson & Johnson that was just given emergency use approval last week. And then, of course, Great Britain and other countries are using the Oxford AstraZeneca, which is going to be under review in the US in the coming months. And, of course, Novavax, which is another American vaccine, with a very different type of platform. Instead of using mRNA or a virus, it actually has bits of protein, or actually the protein, the receptor on the outside of the virus that's actually in little lipid nanoparticles. And this, we hope, will come before FDA review in the next month or so. So this bodes very well for the future. One question that comes up a lot is, was vaccine development rushed? This is one of the reasons why there's so much vaccine hesitancy. People are fearful that important steps were skipped and the safety was not well demonstrated. So at the top here, what you have is a typical paradigm for vaccine development, where you go through the 3 phases that you're all probably familiar with, of phase 1 and normal volunteers through phase 3. And only during phase 3 does the manufacturer then move to large-scale manufacturing after approval. So the difference this time around is not that we've so much rushed it, but we're more efficient. And instead of waiting until the last minute, the manufacturers began large-scale manufacturing earlier, actually during phase 2 and phase 3 studies, and the FDA allowed them to overlap the 3 different phases. So this is really a new paradigm, and I think one that will go forward and will actually enable the world to roll out new medicines and vaccines faster. The reason we were able to do it successfully is that, at least in the US, the federal government poured over $25 billion into vaccine development. from the federal government, from BARDA and other agencies. And this basically helped mitigate risk for industry so that industry could develop these things without the financial risk. For example, Merck's vaccines were not successful, but they're going to now help. They're going to actually provide production capacity for the Janssen vaccine. And so by funding these efforts very aggressively early on, it was possible for the manufacturers to take a chance and also to start manufacturing the product much earlier. So I call it the battle of the mRNAs, Moderna versus Pfizer. So you have two mRNA vaccines that we've been using for several months. They're very similar, one difference being that the Moderna second dose is given 28 days later and the Pfizer 3 weeks later. The Moderna is a bit easier to deploy because it can be stored in the refrigerator, although the good news is that in the last week, the FDA gave Pfizer the approval to store their vaccine at a sort of typical pharmaceutical freezer temperature, not in the severe cold that was required initially. You can now store it at -25 to -15 centigrade for up to 2 weeks. The good news is that both of these vaccines are really astoundingly effective. The efficacy for the Moderna is about a little over 94% after the second dose, and for Pfizer, it's 95% after the second dose. The other reassuring finding is that these and the other vaccines are remarkably effective against severe disease, possibly as much as 100%. And by severe disease, I mean generally hospitalization and other criteria that are used for severe disease, such as mechanical ventilation, et cetera. These vaccines also engender some protection even shortly after the first dose, anywhere from 50 to 90%, depending on how many weeks after the first dose you look at. So this is good news. Both of these have relatively minor side effects. We'll talk about this a little bit later in more detail, and they seem to work well across all ages, genders, and races. The newer kids on the block are the adenovirus-based vaccines. We don't yet have the Oxford AstraZeneca. This is the one that's been used in the United Kingdom. It has a wide range of efficacy, and part of the reason for that is rather serendipitously, the company actually messed up and they gave half the dose to some of the trial participants unwittingly, and we actually learned something from that. We discovered that they actually had greater protection. And there's theoretical reasons why this might be the case. And so the FDA now has asked Oxford AstraZeneca to go back and study different doses and different timing between the doses. And hopefully in the next couple of months, we'll have that data and it will look good and we'll be able to roll out that vaccine as well. The recent success story, of course, is the Janssen, made by Johnson & Johnson, adenoviral vaccine. This was approved last week. It is a single dose, so this could be a game changer. It can be given once, although I will say the company is also doing a study of 2 doses, so that obviously if they find that a second dose makes it much more effective, we may see it used as a 2-dose series, but for right now, it's 1. Its overall efficacy is maybe not quite as good as the mRNA vaccines at 72% in the US, but again, against severe disease, it's even better. It's at least 85%. And in one analysis that I've looked at, it gave complete protection against hospitalization and death 28 days after vaccination. And this is kind of the theme that we're seeing for most of these vaccines. They may not work quite as well at preventing mild symptoms, but they work extremely well at preventing people from dying, getting intubated, and having the most serious complications. So that's really what we want. Now, one question that also comes up, burning question, is do these vaccines prevent transmission? We don't know. We haven't really been sure. So of course, we've recommended that people get vaccinated, continue to wear their masks, continue to distance, et cetera. Well, these are 2 studies that have just come out recently on the Pfizer BioNTech vaccine. This study here showed a 4-fold reduction in positive PCR tests in individuals at least 12 days after the first dose. So that is certainly suggestive that there is an effect or impact on transmission, because you have to have infection to be able to transmit. And the other study in Lancet, published about 10 days ago, demonstrated for the same vaccine about 72% effectiveness against symptomatic and asymptomatic infection at 3 weeks after only the first dose. And remember, this is a 2-dose vaccine. And that went up to 86% 1 week after the second dose. So, experts would infer from this that in all likelihood, these and the other vaccines will very likely reduce transmission, perhaps not 100%, but they should reduce transmission significantly. And this bodes well for the future. One thing I wanted to throw in there, no talk about COVID would be complete without some mention of the variants and their effects on potential surges. I think a lot of you have probably heard about the specter of another surge. I do believe that it will happen. And this is some modeling done by some of the scientists at the Fred Hutchinson Center, Cancer Center in Seattle, where they've looked at the basically 2 levels of increased transmissibility with the variants, okay, with particularly the B.1.1.7, which originated in the United Kingdom. So on the left, it's assuming a 35% increase in transmission, and on the right is a 75% increase in contagion or transmission. And at the top, you have cumulative infections, and the bottom graphs are the daily deaths. And what you see here is that they are predicting that there will be another surge when you look here at daily deaths sometime between July of this year and November or December. But the good news is when you increase the vaccination rate, in this case in King County, they looked at vaccinations per day. And for example, you go up to 8,000, which is represented by the purple, or rather the dark blue line. What you can see is that this very dramatically reduces the number of new infections, and it also attenuates the surge in terms of reducing deaths. So what it tells us is that the faster we vaccinate now with the vaccines we have, and the sooner we get to higher levels of immunity, the better off we'll be in terms of ameliorating the next surge if and when it happens. So COVID-19 vaccines, are they safe? Yeah, I think they're pretty darn safe. Over 50 million Americans have received them, and over 100 million people worldwide have received these vaccines. So if there were any rare side effects, we would have seen them by now. I think all of you are familiar with the injection site discomfort, fatigue, headache, muscle pain, fever. It's pretty mild stuff. When I give these talks to people, I tell them I'd much rather have this than end up on a ventilator with COVID. And in fact, I would much rather have one of these rare episodes of anaphylaxis, get my EpiPen and walk out of the hospital a day later than have very severe COVID. This is the latest data from the CDC and the MMWR published a few weeks ago, looking at the issue of anaphylaxis, which has gotten a lot of attention. At that point, about 14 million doses of the 2 mRNA vaccines had been given. And the number of anaphylaxis cases, that is life-threatening allergic reactions, was 4.5 cases per million doses administered. That compares quite favorably with the number of such reactions with the flu shot at 1.4 and the 2.5 per million doses of the pneumococcal vaccine. So while it is maybe several times greater, at least as of this article, my understanding is that no Americans died from these reactions. Many were hospitalized, but everybody improved, and for the most part, everybody was discharged. And so I do believe that this is a manageable risk. It's also possible that we will not see as much anaphylaxis with the Janssen vaccine, although it does have a similar chemical in it. It does have polysorbate, which is related to the PEG, or the polyethylene glycol, which is in the mRNA vaccine. So I suspect we will still see some of these reactions. The other thing that the media and the social media have gotten a hold of is these deaths that occur after vaccination. And what we use here in the US is something called the Vaccine Adverse Event Database. And as of several weeks ago, when I looked at it, there were 113 deaths in that database that were reported in proximity to these vaccines. And 2/3 of these occurred in long-term care facilities. Many were in hospice. And when you look at the expected all-cause mortality in this population, it was actually lower than one would expect in these kinds of individuals. And so it really does not appear to be occurring at a greater rate. So we don't think at this point that there's any signal of death after the vaccine. So let's just conclude here with a brief overview of COVID research that has been and will be done at Tulane. I'm very proud of the fact that the School of Medicine has enjoyed a 50% growth in sponsored awards in fiscal year 20. with the School of Medicine leading the way and followed closely by the School of Public Health and the National Primate Research Center. On the left are the total number of studies that are open or have been concluded in the School of Medicine. And what you see here is that we currently have 51 studies that are addressing various COVID issues, with 28 active and 23 pending. Just to give you a flavor for the kind of studies that have been done and that are ongoing, we have a number of studies looking at an understanding of COVID itself, the biology, et cetera. Bob Gary, world-renowned virologist at Tulane, has probably the #1 paper in the world this last year looking at the origins of the virus. Others, including Bob himself and colleagues, James Robinson, John Schifflin, Darlene Fusco, are looking at immune responses in COVID-19. This is CDC funded research. In terms of diagnostics, Bob Gary and Tony Hu are working on serological aspects, assays, and CRISPR PCR, some of which has been published. We have therapeutics in the form of Greg Bix's novel peptide and Jay Coles's fusion protein that look promising. There are people working on prevention in terms of vaccines and also looking at cardiologic complications of COVID-19. I'm not going to go into this in any great depth, but I will mention that we have been a Janssen vaccine site. We're very proud of that. We're also a member of this thing called the Community Engagement Research Alliance Against COVID-19 in Disproportionately Affected Communities, SEAL. So LA Seal, the Louisiana Seal, is headed up by Tanette Crusoe-Wood. It's part of a group of sites around the US, and our charge is to study and understand why minorities have vaccine hesitancy, and then to see what we can do about it. And this includes surveys, focus groups, working with faith-based organizations, NAACP, et cetera. And once we get the data, then that will allow us to shape our education models and our messages to see if we can't improve the uptake of these vaccines in our disproportionately affected minority communities. And the next slide, I will turn back over to my colleague, Dr. Hassig.
This is just a brief summary of the areas that faculty within the School of Public Health have been active in, where we have been focusing on a variety of community efforts trying to ascertain infection and seroprevalence related to COVID. A number of our faculty have been involved in clinical trials for repurposing drugs to ascertain their utility in COVID therapeutics. One of the more intriguing ones is the exploration of detection of coronavirus released by individuals that can be captured in wastewater from various buildings, like college dormitories, for example. And then a variety of studies looking at particular behavioral aspects and targeting populations that are at particularly vulnerable status with regard to coronavirus infection and subsequent clinical outcomes. So thank you.
And that's just so that you know, these slides, I will make these available, and I do have a list of useful websites with some helpful Q&A sites of the New England Journal, Immunization Action Coalition. And I also encourage everybody to sign out for the wonderful Tulane COVID-19 Daily Digest, which is put out by one of our wonderful PhDs in the School of Medicine. And he was doing it several times a week, and he's now doing it weekly. It's a wonderful, real cornucopia of reviews of latest studies on this topic. Thank you.
Great. No, thank you both. That was terrific information. A lot more than I expected, and I think really helpful for information for all of us. So we're going to now start the question section. One of our participants asked, can you get COVID after having it or being vaccinated, and how long is one protected? And I think Dr. Mushatt, I'll ask you that question.
Oh, okay, sure. So the first part of that is, can you get COVID after having it or being vaccinated? Yes, it does occur rarely. There's a very small minority of people that are getting reinfected, and we really need to sequence those viruses. Bob Gary is doing that at Tulane to help the CDC, and it's being done around the US and of course around the world. The US is a little bit behind in that, but we're trying to catch up. The key here is to see if some of these reinfections are in fact different viruses or variants that may be able to escape immune protection from the previous infection. But it does appear to be relatively rare, both in those who've been vaccinated and those who have had infection.
Great. This is a bit of a follow-up question. Several people have asked if there will be future vaccine boosters. Will it be like the flu shot? And if someone had the Moderna shot this year, should they have to continue with Moderna? Does it really matter from a booster perspective which one they would continue with?
Great question about the boosters. I think it's very likely. In fact, Moderna has already completed synthesis of a booster, which is they've tweaked the mRNA to be active against the South African variant. And they've now delivered that to the NIH, to the clinical center, where they will be giving it very shortly, if not already, to normal volunteers in the phase 1. The beauty of these platforms is that they can be tweaked relatively quickly, and the FDA, I believe, is going to allow for an accelerated approval process, so that it will be relatively easy to do this. And if you think about the flu vaccine, which is often grown in eggs, many of the vaccines, and it takes from January until August to get the vaccine out and going, and it usually changes every year. This will be probably a more efficient and speedier process. So I think it's more likely than not that we will need boosters, either to boost immunity and or to cover the variants that will almost certainly emerge.
Okay, great. Dr. Hassig, someone asked, if I'm fully vaccinated, should I continue to get tested? How often and why?
Well, I don't think that if you're outside of an institution that isn't requiring testing, that it's necessary. But I think that because we still have some questions lingering about the capacity of these vaccines to actually prevent infection and subsequent transmission, if, for example, you're a member of the Tulane community, you're getting tested regularly, and I have not heard that that policy is going to change. And so it provides us a way to, in fact, assess the ability of the vaccine to maintain protection, and particularly to understand how long that protection may last. That's one of the questions we do have about the vaccines, because we basically stopped studying them after a relatively short period of time, just a few months. And so continued testing after vaccination would give us an opportunity to see just how long that protection might last.
Dr. Mushatt, you talked a little bit about the different variants. Diego Rose was wondering if you could comment on the novel variants, specifically the South African, Brazilian, and California variants. Do the current vaccines help for all of these? And does the calculation rate for herd immunity need to be redone considering these new strains? Or do we essentially need to start from zero to get to herd immunity?
Yeah, so from what we can tell, the current vaccines in the US seem to work very well against the UK strain, which is the B117. But there's some evidence, of course, that most of them will not work as well against the South African. That's the one that we worry about most. The P1 in Brazil is similar, although it's probably not nearly as common. I think the one that we're most concerned about is the South African variant. And certainly the AstraZeneca vaccine did not work. It only had 10% protection, so that's not being used in South Africa. The Moderna and Pfizer vaccines don't really have clinical data, but they have in vitro data that shows decreased neutralization of the South African variant. And I hate to use the country with these, because we really probably need to move on, to the actual name, because it doesn't really matter where it came from. It is what it is. And the B1351, the South African, will probably become the dominant variant in the US. So that will pose problems. These vaccines won't work as well, but I do think that we can keep ahead of this by changing the mRNA and also the the DNA that's put into the viral vectors. So I think we can keep ahead of it. It's not clear yet, how the California variants and the New York City variant, which is one that, as people are looking at very closely now, will behave. They do seem to be more transmissible. They may be a bit more deadly. But remember, these vaccines they are polyclonal. That's a point that experts make. And so they do make antibodies against other epitopes. And so, there's a reasonable chance that they will still work, maybe not as well, but they will still work. And hopefully they will still prevent serious illness, even if they don't present maybe a cold-like syndrome from COVID with some, cough and sore throat. But what we really want is prevention of death and hospitalization.
Thank you.
And I think one additional thing is that the Johnson & Johnson was actually tested extensively in South Africa. And while it didn't perform as well as it did against other variant viruses, it did do a pretty good job against what we now would think of as a South African virus.
Right, and I would just, to the credit of Janssen, the Janssen vaccine, I would say that, this 72% figure in the US, remember that vaccine was tested quite a bit later than the 2 mRNA vaccines. So it had more of an acid test. It was up against more variants compared to the Moderna and Pfizer that were tested mostly last year when we were dealing with the, not the wild type necessarily, but the early variant that was relatively, that the vaccine was targeted against. So I think that, Dr. Fauci would say that unless you compare these vaccines head to head, you can't say that one is not as good as the other.
Yeah.
Okay, great. We have questions coming in thick and fast from Brett Aaron. Are there any studies looking at adverse outcomes in patients simultaneously infected with COVID-19 and influenza? And I will let you two fight it out over who answers.
I mean, I know there have already been studies in other parts of the world looking at this. And surprisingly, as I recall, there were studies published a few months ago. There wasn't really much of a impact. But the interesting thing is in the US and certainly in Louisiana, New Orleans, we're seeing almost no influenza. And this is the silver lining. Because more Americans than ever are wearing masks, social distancing, and cleaning their hands, influenza has virtually disappeared. Colds are, most of my colleagues haven't had a cold in over a year. And I wouldn't be surprised if this will affect our future, much as it happens in some of the Asian countries, where we may very well decide to don masks between November and January so that we don't get the common cold and so we don't get the flu. But it's really interesting how little flu there is at this time.
Yeah, there's been almost no flu, and it may also be influenced by the fact that kids haven't been interacting with each other quite as much as they normally would, because they are tremendous distributors of influenza virus as opposed to COVID.
Great. I have two questions that are related to that a little bit. The first one is from Bridget Bunda. Do you mind speaking a bit on any updates on COVID and related vaccines and children?
All I know is that the studies are ongoing. I haven't seen anything published. When I looked at that a month or two ago, I know that they were having a little trouble enrolling kids into these studies. Obviously, parents may be a little bit nervous. Children are what we call a vulnerable population. And so they require extra safeguards when it comes to clinical trials, just as pregnant women are. But they also have every right to be part of research. And it's unfortunate that, studies such as these vaccines are done in older people, but that's just the way it is. You generally do children later. But I'm not familiar with any data on that at this time.
Okay.
To my knowledge, the most advanced studies are down to 12 years old. And I would expect that it's probably going to be, because of the smaller numbers in the study, it's probably going to be several months before we have definitive answers regarding adolescents and above.
Okay.
There's no studies that are.
Sorry. Another question about more of our vulnerable populations. After someone is fully vaccinated, is it okay for them to visit elderly relatives who've also been vaccinated inside their homes and visiting with or without masks?
That's the question of the hour.
You want to try it, Susan, or do you want me to try?
I will say that I think it is, especially if the vulnerable member of the family, the grandmother, the elderly aunt, the uncle, have themselves been vaccinated and the individuals visiting have been vaccinated, I think you're good. I would, be careful again, with perhaps avoiding large gatherings in the week before you go, just to make sure you don't pick up anything. But I would say yes, if all parties are vaccinated, I think you're in a much safer place and can give a hug.
I would agree. There's no such thing as zero risk in this world, and there comes a point where
Right.
I imagine the benefits, mental and social benefits of making these efforts to connect with people outweigh the small risks.
Okay, great. We have a question. If the recent COVID demographics have changed, or are the same populations getting sick and dying?
The basic demographic profile has not shifted dramatically. The individuals who are essential workers are still out there interacting at risk. And with the exception of the essential healthcare workers, most of them have not yet had access to vaccine in any substantial way. So the risk of exposure is still there for people in those kinds of positions. And so the information I've seen, I haven't seen any movement in a major way as the subsequent cumulative assessments have emerged from the CDC on a national level. So I do not know if we hopefully will start seeing variation and decrease in infections in elderly populations and decreasing hospitalization in those populations, since they were some of the first people to get vaccinated. So I'm hoping we will see those changes. But in terms of, for example, ethnic minority populations, Latinx and African American, I have not heard of any substantive shifts.
I did see something yesterday about a dramatic fall in deaths in nursing homes in the U.S., which is attributed to the
I saw that
vaccination rate. So that certainly is great news.
Okay, that is great news. A question from Vidal Villegas. Is there any verity to the belief that reinfection always results in less severe disease?
No, there are people who
No.
have gotten sicker with reinfection. One of the fears early on was that, as with dengue, perhaps a second infection or the vaccine would actually make you worse. It's called antibody-dependent enhancement. The good news is that is not panned out with the vaccine and largely with reinfection, but there have been some people that have gotten sicker. But fortunately, getting reinfected is quite rare.
Great. Now, the next question I'll have each of you answer in turn. We'll start with you, Dr. Hassig. What are the biggest challenges that you see moving ahead?
I think the biggest challenge from a public health perspective is still the somewhat politicized divide about the mitigation measures that are so important, even as we're rolling out vaccine. The attitudes towards mask wearing and maintaining distancing and avoiding gatherings that aren't essential. I think that's going to continue to be a problem, because I'm concerned that we're going to have a substantial portion of our population that may not choose to be vaccinated for a variety of reasons. And that means that we're going to have to deal with a persistent mitigation approach for some time until we can convince them or figure out some other way to enhance immunity.
Dr. Mushatt?
I would completely agree. I think for me, one of the top ones is vaccine hesitancy. While it's gotten better, it does persist. And when we look at these graphs, like the ones that we show, where we show that by such and such a date, 70% of Americans at this rate will be vaccinated, that's not necessarily assuming that 30 or 40% of people refuse the vaccine. So that could actually put a kink in the works. But that's why we have things like the SEAL grant and many other efforts trying to get the word out there, trying to get good scientific information out there and sort of dispel some of the myths, like nanobots being in the vaccine and the vaccines interfering with fertility and all these kind of things. And while I understand where people are coming from, we have to fight misinformation. The other thing will be the variants. It's going to be an ongoing challenge to stay ahead of the variant. This virus does mutate faster than originally predicted, but we're used to that with the flu. The flu does the same thing. So I'm confident that we can handle it, that we can stay ahead with the kind of technology that we have. And then the last frontier will be vaccinating children, because there are a lot of children who get this. They often don't get very sick, so we're not even aware that they carry the virus. And they can continue to be reservoirs for this virus. And if we don't get kids vaccinated, there is a possibility that we'll keep reseeding the population. And so we need to get some data on safety and efficacy in that population.
Absolutely. So the other side of the coin, what are the opportunities, if any? Has COVID changed the way we think and live, and has that affected us in positive ways? This time, I'll start with you, Dr. Mushatt.
Well, I certainly, as I alluded to earlier, it's quite remarkable how little flu there is this year. And so I think, if nothing else, to me, this proves the efficacy of these mitigation measures. You don't need a randomized controlled trial to know that the only thing different is that more people are wearing masks, more people are distancing, and more people are cleaning their hands. And so I hope that going forward that we learn our lessons and that we continue to apply them in future years during flu season. So that's a very important thing. I think the other thing is that it's very exciting to see the new technologies in vaccine development. I just saw some news that there's been some success with a universal flu vaccine and a monkey model. I think it's the NIH study. And I see no reason why mRNA vaccines can't be used along these lines to provide more universal vaccination against different strains, perhaps longer protection. But there's a lot of hope that this is a transformative moment in vaccine development like never before. And the timing was perfect. I mean, the mRNA vaccines have been around in some form for decades. They've looked at them for cancer and Ebola, but not at this scale and not with this degree of efficacy. And so I think the time is now. We need to seize the day and go forward. And I think the other thing is that in many ways, this pandemic has showed really extraordinary levels of cooperation and collaboration between scientists and peoples around the world. Certainly there's examples of the opposite, but I've never seen so much data flowing so fast between so many different people. It's really remarkable. And I think this bodes well for the future.
Okay, great. A silver lining. Dr. Hassig.
Well, I'm going to take a little bit different focus. And I think that this pandemic has reminded us, and in some cases perhaps informed us, about some of the underlying disparities in our society. And from the point of view of making us a better society here in the United States and a society globally, I'm hoping that we will use our recognition of health disparities, for example, between different segments of a population and between countries, to really galvanize action to ameliorate those and make a better framework for better health for a much broader population. And I'm hoping we don't forget what the veil has revealed, pulling back the veil has revealed.
Right. Thank you. The man behind the curtain, right? See what's happening
yes.
there.
But we need to pay attention to the man.
Absolutely. I'm going to call on one of our participants to ask his question live. Ken Tedesco, would you please ask your question? Do we have Ken on? Ken, you're muted. Okay, we're going to go on. I'll read his question aloud so we don't lose any time. Ken Tedesco asked, Pfizer and Moderna are mRNA platform vaccines, while the Johnson & Johnson is different and is an adenovirus vaccine. If my patients have had an mRNA vaccine, would it give them additional immunity to get the Johnson & Johnson vaccine also?
So Ken, that's a great question. And the official line right now is you should complete your series with the same type of, same class of vaccines. So if you got the mRNA, complete with mRNA, and ideally with the same one. Now, if somehow you have a patient who comes in and says, I don't remember, but I know I got the mRNA, you can give them whichever one you have. And indeed, now that Janssen is available, the CDC is saying, well, if you don't know what they got, you can even you can go ahead and give them the Janssen vaccine 28 days later. The problem is we don't have data yet. We don't know whether using a different vaccine then the original one will work as well. But there is some reason to believe that it may work as well or even better. There's this concept of heterologous prime boost vaccination, which is used for HIV studies and Ebola and other things, where you give different components or different vaccines at the beginning for the prime and then for the boost. And so it's quite possible that, and there actually is a study in the United Kingdom now, I found this. It's AstraZeneca and others I think Oxford is doing this. They're going to give the AstraZeneca and the Pfizer vaccine sequentially, one first and then the other, or vice versa. And they're going to actually look and see. So we should learn, and later this year, whether this is a reasonable approach, and B, whether perhaps it's even a better approach.
Okay, great. We're going to try this one more time, and we're going to call on Dr. Michelle Longo. Dr. Longo, you have a question? Loving technology tonight, folks. Loving technology. How's that working? I will just read her question. How long after having COVID can one be tested for antibodies? And is there a waiting period between testing for antibodies and getting the vaccine?
I'm not a big fan of antibodies, although I will say, and the reason is that we don't know for sure how well they correlate with protection, although I will say there was a recent publication, I think it might not be fully published in the last week, that did show that the commercial antibodies do seem to be reasonably accurate and good predictors of prior infection. But that being said, if you really want to know whether you had COVID, but if you had COVID and your PCR is positive, I wouldn't bother getting the antibody, because even if it's negative, you may still be immune. And the reason for that is you may have T cell immunity in the background that we can't measure very easily. But if you really want to know, I would probably wait, 2 to 3 weeks at least after you've had your infection. By then, the IgG antibodies should be peaking. If you get the antibodies within the first 5 to 7 days, they're sometimes negative, but somewhere out at about 10 to 21 days is when you get a really good response. And so if you really want to know, that's probably the time to do it. The second part of the question was, is there a waiting period between testing for antibodies and then getting? No, there really isn't. So if you had COVID, you should still get the vaccine, but the general recommendation is wait until you've recovered from the infection. Generally speaking, wait until you're out of isolation, which is at least 10 days. If, however, you're on the fence or it's hard to get, you're probably okay for 90 days, because the evidence so far is that we're probably protected for at least 90 days and probably longer after you have COVID. So, in that case, you could wait 90 days to get the vaccine. But if you want to get it right away, get it once you've recovered at least 10 days after diagnosis.
Okay, great. Operator error on my part. I give my apologies to Drs. Longo and Tedesco. My timing was off in giving you time to come on and ask the question yourselves. This question, I believe, will be for you, Dr. Hassig, but I may be wrong. Are you confident that the vaccine will be available to populations around the world and to developing nations? If not, how will they gain herd immunity?
I think we have to make sure that it's available. That's what the COVAX project is, the multinational, international project that President Biden has agreed to allocate resources to from the US. And I think it's truly important. The Johnson & Johnson vaccine, for example, with its minimal cold chain requirements and its single dose delivery process is going to be very likely one of the major components of global vaccination. Oxford AstraZeneca has also pledged themselves to deliver large quantities of AstraZeneca to poor nations at minimal cost. It's one of the least expensive of the vaccines that are currently available. And so I think it's both a commitment on the part of the pharmaceutical companies that are producing the product, as well as what we might normally consider donor nations, to make sure that we are facilitating that distribution, perhaps with logistical and technical support, and probably for many nations, financial support.
Okay.
Because without the whole world being protected, we won't be protected. So it's everybody's in the same boat on this one.
Okay, thank you. Thank you. This is a question about coast to coast. California and Florida took very different approaches to dealing with COVID-19, yet their numbers are quite similar. How is that explained?
I actually, I was looking at comparing some states earlier today, and two of them that I looked at were actually Florida and California, because they both had such major outcomes and impacts. What was really interesting is the timing of their interaction with coronavirus was very different. California had a relatively, I would call it kind of a slow burn through much of the early years, the early months, even though they were one of the first places we found COVID. They had kind of a slow burn level of cases and illness. And even through the summer, they were at a relatively low level, and then they just shot up, which I think may reflect, and Dr. Mushatt may have some thoughts about this, the emergence of what we're now calling a California variant of SARS-CoV-2. In Florida, they had a relatively low engagement in the first surge that New Orleans experienced and New York experienced, but they really had a tremendous burst in the summer. They were a major contributor to the summer surge, and have in this winter surge as well had a very long and prolonged high plateau in Florida. What is interesting is that on a per capita basis, they're pretty much the same. But on the recent cases, Florida's in a much more precarious situation than California. In the last 7 days, Florida's got about twice as many cases per 100,000 as California does. So I think this disease is very heterogeneous in terms of how it's had an impact on different locations. And California's population, with the very large concentrations in LA, for example, that was just a roiling hotbed of infection and transmission in the recent months. Whereas Florida had, kind of waves. Miami and Miami-Dade has been a problem area, as well as scattered throughout the rest of the state. So the challenge with this is it's not what you do at one point in time, it's what you do for an extended period of time. And so if you don't maintain control and mitigation efforts, this virus is going to take advantage.
Okay, it's a smart one, as we continue to see.
It is tricky little.
We're going to go with the third time's the charm and give Dr. Tedesco an opportunity to ask a second question.
The second question, thank you. Can you hear me?
Yes.
Yes.
Okay, thank you. So assuming that we have to take, have to get a vaccine next year and every year, similar to the flu shot. And if I had Moderna this year, or if I had Pfizer, what is the protocols that we know of right now as we move forward to get another shot, a booster shot, whatever you want to call it, as we, every year from now on?
So, I mean, it's a good question, and there are no protocols right now. It's just too early to know how the CDC, the FDA, and others are going to handle this. But, presumably what will happen is, you will, and everybody should have that little CDC wallet card so to keep track of what you got and when you got it, sort of like a vaccine passport. I don't know that it'll be a formal passport, but there is some talk about doing that. But, once we figure out what's going to happen with this epidemic in the next 12 months, and once we figure out whether boosters are needed, then there will be, there'll have to be a federal and state program, just so as there has been for everything we've done so far, to roll this out. I will say the good news is that I just saw some data yesterday or today looking at the one of the booster doses for the mRNA vaccines against the South African variant. It does look promising that it will also protect against the other variants, so that it won't be necessary to have to combine that with another one, et cetera. And that, if that pans out, that will be very good news. But I'm sure there'll have to be a very good system for this going forward. That's something I think we've learned a lot about, the importance of public health, tracking, contact tracing. This country has been terrible at at sort of compiling this kind of data and funding the states to do this. They weren't ready for this at all, for this magnitude of a problem. I think that's going to change. I think you'll see states getting better funding, and the feds will have to lead the way in terms of tracking this and informing everybody, you know, how we go forward. But yes, I think that may be necessary, and there will have to be a system. But I suspect that nobody's figured that out as of yet.
Thank you.
I also saw a piece of research that was suggesting that it might not possibly need to be an annual vaccine, maybe an every other year kind of booster, because once we get these massive amounts of transmission that are going on now squelched through the initial vaccination, it may not generate as much variance as quickly.
Well,
Great. So we have just a few minutes left. I'd like to give both Drs. Hassig and Drs. Mushatt a moment to share any final thoughts with our audience.
Susan, I'll let you go first.
Okay. Well, I think that part of what has been demonstrated, I think, by the questions that you all have asked and the answers that we've been trying to provide is that we are still in a mission of discovery with regard to this virus. We have learned an enormous amount. And as we gain more and more experience and understanding and have more data available to us, I think our understanding is going to become clearer. We'll be able to answer more of the questions that we all have. And so I would encourage everyone to recognize that this and support the idea that, you know, science finds new things out, and then what we think needs to happen is possibly going to change. And so I think that it's important for us all to keep in mind that we're going to continue to expand our knowledge base and hopefully optimize the utilization of that knowledge to make this pandemic go away sooner rather than later.
Thank you. Dr. Mushatt?
Well, as Dickens said, you know, this is the best of times and the worst of times. So, you know, certainly in many ways, there are silver linings here: less flu, better compliance with hygiene measures, better understanding of vaccinology, you know, new ways of making vaccines faster and more effective, and more collaboration in science. Many, many, many good things are coming out of this. But as Dr. Hassig mentioned earlier, this pandemic has also revealed the dark underbelly of American healthcare. You know, the implicit racism, the discrimination of various sorts are brought out, and I think we're realizing that social determinants of health are incredibly important. They need to be taught in medical school. They need to be addressed. And we need to, you know, we need to take care of everybody in our society. You know, we're only as good as our weakest link, or our most disenfranchised group. You know, that's how a nation should be judged in terms of, you know, do we take care of our people that are down and out, that don't maybe have as much access? We need, because in the end, you know, as Dr. Hassig said, if people, you know, 10,000 miles away are not getting vaccinated, and they you know, amplify the virus, this virus is going to get worse. It will not go away. So I'd like to see us reaching out more in these areas and making more inroads. We've got a long way to go, but I think that we can do it as a nation.
Great. Thank you so much, Drs. Susan Hassig and David Mushatt. We appreciate your time this evening. And I want to thank all of you in the audience for joining us tonight. Just a reminder, if there were any unanswered questions in the chat, they will be answered individually by email. And also you will receive a recording of tonight's webinar. Thank you again, and good night.